Well, Corey, I think, talked about tilt, so we could just move on to the next topic. But I think I do want to start off with a simple tilt solution, if that's even something that's even possible. I think this is a very complex topic, and there are my relevant disclosures that we're hoping to kind of add some clarity to. If you think about the head in the sand, which is kind of where I was at with pelvic tilt, I would go to these lectures by Vidorchik or others, and I would literally just leave the room more confused and more unenlightened. And that would give the same default answer that a lot of us give, which is, well, I don't really have a lot of dislocations, so I'm just going to keep doing what I do. And of course, none of us in this room have dislocations, but somebody's having them. And I think Corey mentioned this as well, since about 20% of our revisions are for instability. So they do happen. Are they always because of tilt? Probably not. But we definitely know more and more about this topic that a percentage of them are. And there's been a lot of innovations that we can talk about to try to address instability, whether it's for tilt reasons or others, whether it's dual mobility, better technologies. And we really wanted to kind of create a solution that would probably be scalable in a way that we could really enlighten everyone on how common tilt is. So with Cuptomize, which is an integrated tool into VELOS hip navigation, we developed a product that really allows us to really take it full scale. Is it going to be a complete technology? We'll have to see. But what it does do is it simply allows us to understand who's at risk for tilt, which I think is a very big unanswered question. And can we do it in a way that is easy to accomplish in a preoperative setting? If you have somebody that's dislocating, can we determine why are they dislocating? Is there a tilt reason? And then can we take it full circle in the operating room? Instead of getting all this analysis preoperatively and then being in the OR and not really understanding how to execute on your plan, can we take it to what we're doing already? And a lot of us are already taking x-ray, so there's a way that we can continue to take an x-ray but just get that preoperative data in there. And one of the things we can all learn about preoperative risk factors for a pelvic tilt issue is the stiff spine, right? And everybody says, well, if your spine doesn't move a lot, if you have a stiff spine that requires more motion through the hip, therefore, as Corey mentioned, when you sit and stand, that cup is obviously going to move different than when you're looking in the OR. And if your spine's not moving, that means a lot of hip motion has to come through your hip. So stiff spine is one of those clear things that we all know is a risk factor. But can you just look at an x-ray and be like, oh yeah, there's hardware there, so that's my problem child. But the problem is problem childs don't always just show their face with hardware. And if you look at some of the studies from Vidorchik, and you look at stiff spines, 80% of them actually have no hardware in them. So if you look at hardware in your x-ray and be like, aha, this is my guy I need to use dual mobility or worry about, you're gonna miss 80% of them. So we need something better and more scalable. And I think we all know with current technologies, whether it's Mako with 4.0 or with OPS, there's a lot of great technologies out there for tilt. Ultimately, both of them require a CT scan at some level. And I think if we're talking about most doctors that want to address tilt, are they only going to get a CT scan just to evaluate tilt? And I think that's something that may not relate to everybody. We were hoping that we could get maybe just a couple additional x-rays and at least tell you a couple of important details. Do I have a problem child with tilt? And if I do I need to think about my target differently in the OR? And then lastly, when I'm in the OR, how do I make sure I complete that plan? So with 2 additional x-rays, with 2 lateral standing, lateral sitting x-ray, we can develop a plan. And I always like to describe the technology in a case setting because I think it relates to more people. So you always got to be careful when you send me an x-ray because you never know when it'll end up on a talk of mine. But one of my friends did send me one of their x-rays of this case. And it's interesting because when I looked at this x-ray initially, I looked at the x-ray on the left hip and I'm like, oh, I know where the problem is. There's no anteversion. And actually, it's the hip on the right that ended up having a problem. This is the x-ray of this patient they did a hip on from the front when the patient was on their back. And ironically, he put it in a position where that's not where the problem happens. And if there's one thing we can all remember is patients don't always dislocate on their back or on their side, which is where most of us put, in this meeting, we're mostly on our back. But when we look at that cup in the OR, I'm like, oh yeah, that's a good looking cup. We really don't know what it looks like when they're gonna have a problem, which is standing or sitting. Well, look at this cup now when the patient stands. So it would have obviously been nice if he knew that when he put the cup in, and now the cup on the left, which I was making fun of, looks pretty darn good. So here's a cup that really looks very differently when the patient stood up and this patient dislocated on standing. And when you get these 2 lateral x-rays preoperatively, you would have gotten this planned preoperatively. And with those 2 additional x-rays, every patient that you want to analyze will get this plan. And whether they have a risk factor or not, whether it's a stiff spine or whether their tilt is creating havoc in a way that you got to change your cup position, you're going to know it immediately and efficiently. So most of the time, of course, you're going to get a green on the patient risk factors. It's going to say, you know, this is business as usual. But there are going to be those percentage of cases, 10, 15%, where you do need to think carefully. Is this a case for dual mobility? Is this a case where I need to be very precise on my cup position? And that's what this analysis would have told this doctor, is if they put their cup in that 40-20 position on their back, that would have looked 35 standing. And that's getting to the point where we're running into trouble. In fact, this would have been the intraoperative analytic that he would have gotten in the OR if he took an x-ray. And it would have said, your cup's in 41-22, which I think a lot of us on an anterior approach would have taken any day. I know I would have. That cup looks pretty good on their back. But of course, what the OR would have told him also with this new product is that red ellipse is highlighting a standing anteversion of 37. So even though that cup looks good when you put it in on their back, we know we're going to have a problem with that patient standing. We would have known it preoperatively, and we would have, of course, known it intraoperatively, and the software would have told them, dial down your anteversion to a more appropriate level, and then you always can consider whether you need other stability metrics like dual mobility, more leg length, more offset. So I think it's important to understand that with pelvic tilt, of course, hips work most of the time well. They're not dislocating all the time. I think we all acknowledge that. But when they do dislocate, I think a lot of the times, if we would have known what we knew after surgery before, we could have made things differently. So we're all about reducing risk. Most of us in this room have great outcomes, and that's always what we're going to remember. But sadly, when we leave the office, it's usually one patient of the day that will remind you that we're not perfect. And we're all about reducing risk. Dual mobility is, of course, one of those beautiful features that we have that can reduce risk. And I think we can all acknowledge in this room, or maybe we can't all acknowledge, but I would acknowledge that I don't think dual mobility is for every patient. I don't think there's no free lunch in this world. I think we've learned that over and over again. And I think it would be really nice to know who needs the big guns and when do we need to use dual mobility. I think we could also agree if we knew a patient wouldn't have a problem with a standard bearing head, maybe we would use that. But if there's somebody that has additional risk, that is when we do it. And dual mobility is growing, as you can imagine, to the point where a lot of patients or a lot of doctors are using it on every patient. And I think it'd be nice to know preoperatively who needs dual mobility. So with this technology, with a matter of 30 seconds after getting your x-rays, you're going to know, do we have a problem child? And would we consider something like dual mobility? And do we need to think about a cup position based on this algorithm? Do I need to do more than 40-20? Do I need more anteversion, less anteversion? Can I even solve this problem with the cup position alone? These are nice things to know before the OR. And then, of course, in the OR, it'd be nice to know that you can hit this target, whether you're doing an anterior approach or a posterior approach. So in conclusion, because I got another talk to do, cup demise is a great way to really get a quick pre-op plan without a CT scan. You could do it on every patient if you wanted. You could do it on problem childs if you were smart enough to know who they were. But really, it's a great, quick, and easy way to know who do we need to think more about with pelvic tilt, and then how do I plan my case in the OR. It integrates well into VeloCyp navigation, so if you're taking an x-ray already in the OR, it will then correlate to your patient's pre-op plan and let you know not just what your cup looks like as you're putting it in, but what is it going to look like in those functional risk positions of sitting and standing. All right, stem extraction. So I want to, relevant disclosures again. So you guys have probably seen the booth. A lot of you probably already know about this product with Watson, but this is the picture of most surgeons before or even after they do a removal of a stem. It's probably the least fun part of our job is taking out a well-fixed stem. And whether it goes smoothly or doesn't go smoothly, it's a stress-ridden event. And it takes a lot of time. It often is dealt with complications. That's why a lot of us that do them really have to know how to deal with the problems that sometimes ensue when you take out a stem. So whether it's patient morbidity, whether it's OR time, whether it's blood loss from an ETO or unintended ETO, as I call it, I think it's an important thing to understand that this is a problem that really needs a better solution than what we currently do. And I know I only have a few minutes, but I encourage all of you guys to go to the booth and speak to Jose and Gerhard Rivera about it. This is by no means my idea. I'm talking about it, but it is such an inspiring story to hear about someone in the OR with a surgeon doing an ETO and being like, God, there's got to be a better way. And I think a lot of great stories start off that way, and this is a story better heard from him than me. So we want to have a smiling patient, and this is one of the things that, you know, can create a much easier journey. And there is a video which, because of interest of time, maybe I'll skip because you can see it outside, but these blades are really invented in a way to allow us to take out well-fixed stems in a more intuitive way. And I think anybody that's used this, which a lot of us probably already have, it really creates a aha moment in your own mind, like, hey, why didn't I think of this? Like, why am I using straight osteotomes to take out a curved stem? And I think we all realize the problem there. You're taking straight osteotomes, and at some point the stem stops being straight, right? And you got to deal with, how do I get around the curve, whether it's on the outside or the inside. And of course you can't see what you're doing anyway. So here you are, you're blind to what you're doing. You're impeded by the trunnion on the inside of the stem or the trochanter on the outside. So you have these issues, and you wonder, well, why isn't there a better way to get around that corner? So if you look at how on a wedge stem, for instance, changes in its dimensions, we got to get a device to get around that curve easy and smoothly, and that's what this product has invented. It hovers the curve, the natural curve of the implant, and with better sizing, it really can make this process easier. On the inside, once we get those first few millimeters with your straight osteotome, we're dealing with a trunnion, and we can't get around it, and we break the calcar or worse. And once again, this design allows it to hug around the trunnion and slide down. Fit and fill stems, similar issues. It allows you to laterally hug the stem, and inside exactly the same way. One of the great things about this product is that there's a lot of field experience about there. Anybody who has a LinkedIn account, I'm sure, has seen it. And this field experience has been with a lot of excitement about a product that happened very, very quickly. Taking out well-fixed stems in remarkably quick times, leaving bone cavities that you're putting primary stems back in there. This is the kind of thing that really created such excitement for us that do revisions. And I think, when you think about Watson 2.0 and its re-release, it's doing things in a way that allows us to get it out there in a better fashion. Not that version 1.0 wasn't great, it was, but whether it's sizing, we want to make sure we get the sizes for all implants. Whether it's our ability to make this more prepared before surgery. I mean, we know dimensions of stems now with all this technology. So we want to make it software enabled, and that's just not because I love software, although that's part of it, but we want to be able to say, okay, if you know what stem you're taking out, let's tell you what blade to use. So this is the kind of way that we can really enhance what's already been done. We do want a software-enabled solution here preoperatively where you can not only learn the education piece of how to use this, although it's very easy to use, we want people to see exactly how to use it before they get the OR. When you're actually planning your revision, we really want to see this as a revision tool for all revision type cases. If you know what you're taking out, whether it's through automation, implant recognition, or if you know the stem size, we know the dimensions of all these blades that we're manufacturing. There is an intraoperative caliper you can use, but you're going to know exactly which blades to use so that when you get in there, you're already prepared. And then, of course, after you're done, if you want to get your AI detection before you start the case of what stem's in there, we'll be able to iterate that as well. Lastly, when you're done with the case, we're going to be able to create this real beautiful database of revisions. What stems were used to get this, what stems have been taken out, what blades were used, what stem went back in. Obviously, from our sales component, we're able to create inventory controls. So unlike my explant at my hospital where the blades are only replenished when they look straight, we'll actually know when the blades are used so that we can replenish them in a proper fashion. So this is how the software can enable an already great product. But obviously, I'm trying to go quickly through this topic, but if you haven't seen this product, you really, really need to see it out there because I'm telling you, to be able to take out well-fixed stems in a way that it becomes stress-free, I think is the holy grail. Thank you.